He is the, thank you, thank you. So he is the transfusion medicine person who has been, you know, forming this organization and the founder of AATM. So, Dr. Hatim. Hi, Dr.
That's
Hatim.
a pleasure to meet you all in this, and it's my honor to be back now. Thanks for Dr. Twarijik for always connecting us with the international world. So, just to share knowledge.
Your voice is not clear,
Yeah,
Dr. Hatim.
voice is,
Yeah, voice is not
Now,
clear.
yeah,
no, voice. There is some voice. This thing.
Is there two instrument you are keeping opening? Sometimes happens.
Yeah.
yeah. But now it's okay or still?
Yes, now it is okay.
Now, sometimes it's okay, but sometimes it's leaving. I think first when you spoke, it was going on very well. So that
Yeah,
was good.
maybe there's some echoes here. So
Okay.
thanks for being here, and
Yeah,
it's
now
my
it's
honor. Now I think it's okay. Huh?
yeah, now it's better. Now it's better. But still there is some sound from the back.
Background sound.
Background sound.
Yeah.
So, Dr. Asa, I just talk in between because we had this ISBT yesterday. That's why this background is there. Otherwise, it is always a sea beach. So I'm going
No,
back.
it's yes. But I like this. I like this background. Definitely. I should download this also so I can.
I mean, whenever we are doing official, you can have this one. This is our
Thank you.
ATM official.
Yes, thank you. Thank you so much. So I think should we still wait for 5 minutes? We're just at 1 o'clock now here and 2:30 in India. So we'll wait for some this thing. Um Abhishek, can you have my slides on the screen so we can have the Atom webinar, so people know that they are here and they are joining? I think Dr. Hatim, are you sharing the slide? Can you stop sharing? So I will share mine and then you can share yours.
I'm not sharing. I'll stop sharing.
You're not sharing? Okay. Abhishek, are you able to share? Hi, Abhishek, are you here?
Yeah, I'm there, ma'am.
Yeah.
I'm there.
Yeah. Are you able to share my slides?
Yeah, 1 minute.
Yeah, sure. No, I just wanted to have that background so all the people who are joining in, it would be nice. Yes, thank you.
Yeah.
Thank you. Yeah,
It's there.
that's perfect. Perfect. So we'll wait for some more time or should we begin? You can let me know. I'm okay both ways. I always love to talk about the weather, what's happening in different parts of the world. If anybody wants to say hello on the mic, please feel free. Where are you joining from? I see quite a few people. So me, Dr. Hatim, and again, we're joining from the UAE. I'm in Dubai. Dr. Nagin is also in Dubai, and Dr. Hatim is in Abu Dhabi. Dr. Chaudhary, where are you from?
I am in the remote part of India, Actually, I am in the
Yes.
most hinterland, most eastern part of India. It's almost Myanmar border. And Delhi to
Beautiful.
my place, non-stop air travel is 3 hours.
Wow. Yeah.
If I
So
go
I
other
reach
side,
faster.
yeah. If I go to the other side, I'll reach Dubai.
That's nice. That's nice.
Okay.
Absolutely. Absolutely. Anybody else who wants to join in and open their mic,
Hello,
say hello.
hello. I'm Dr. Jyotsna Agarwal. I'm from Delhi.
Hi, Jyotsna. Good to have you here. How's the weather there? Is it still cold?
It's better now, slightly warm and pleasant.
Nice. Wonderful. Wonderful. I can see Dr. Manitha, Nasrin. Nasrin, thank you so much. I'm happy you could join. Mara, Joy, you as well. Anybody who wants to say hello, please feel free to just add.
Hi,
Hello.
ma'am. I'm Dr. Sekunda.
Hi, Sekunda. Good to have you here.
Yeah, how are you, ma'am?
All good, all good. So
Yeah,
good to have you. And hopefully, you'll also be our speaker next time.
yeah, sure, ma'am, sure. More
So
than happy to be.
wonderful, wonderful. And this is a nice thing that we are starting now. So we can see Dr. Abhishek. Abhishek has joined as a co-chair, so he's supporting me on the ground. And Abhishek, would you like to introduce yourself? It would be nice.
Yeah, good afternoon and good morning wherever you are. And I'm Dr. Abhishek. I'm presently working as a faculty in Department of Transfusion Medicine at JIPMER, Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry.
Very nice. And I
Pondicherry
love
is,
that. It's a beautiful beach. It's a
yeah,
beautiful place if you
east
want to
coast
go
of
for
India.
vacation. Yes. Dr.
Yes.
Hatim, we should think of doing a workshop now. So, Dr. Hatim's background is also in HLA. He is a world-renowned faculty and he has been working in that as well. So, I'm sure I'm going to introduce him and then you know, let them speak about themselves as well. But anybody wants to say hello, please feel free to add yourself. I see a lot of familiar faces, a lot of familiar names, and it's wonderful to have so many people on a weekday. And maybe next time we can think of doing it on the weekend
Dr.
as
Manita
well.
from Mars.
Hello, so good to see you, Vanita.
Yeah, not from Mars, from Nepal.
I know, I was like, you should have the Everest behind you, the Mount Everest.
Mount Everest, yeah,
Absolutely,
famous, yeah.
absolutely.
Mm.
This is
So
fantastic.
yeah, everything is okay. But yesterday, sorry for yesterday, I was so busy managing blood in
I
hospital,
know,
so
I
I
know.
could not attend the meeting. My apology for yesterday. And today
No
I'm
worries.
here. Today I have time, so.
This is wonderful. No, we try to keep it in such a way that more people can join in. So I think without further ado, we are at 1:06 p.m. So I would like to, yes, hello, Dr. Tarek. How are you?
Hello, everyone. Nice to
Okay.
see you all
Alhamdulillah.
today. It's Tariq
Wonderful.
under the umbrella of the greatest leader, Dr. Hatim. Nice to
Wonderful.
be with
Yes.
you today and hope it will be
Amazing.
a very
Amazing.
informative
Amazing.
session and looking forward for more collaboration.
Absolutely, absolutely. And this is what is the purpose of this association as well as starting these webinars. And please feel free to reach out. We'll also be starting a few projects, working on a few projects through Atom, this organization. So we can talk more about the collaborations and different things which we can do. So good to have you here. Thank you so much.
Thank you. Thank you so much.
Thank you. Is there anybody who wants to say hello? And then I will introduce our speakers and introduce Atom because many of you are joining for the first time. So we thought we'll start with a little bit of introduction. So thank you so much. Before I start, just a few housekeeping notes. One, please keep your mics mute if you're not speaking, and we will give you. So I will first introduce today's topic, introduce our speakers, and then after introducing our first speaker will speak, after that our second speaker, and then we'll have a Q&A session at the last end. But please feel free to message in the message box or the chat box your questions so that we can ask it to our speakers today. So without further ado, I just wanted to introduce Atom. These are dedicated Atom webinars, which we're just starting for the cell therapy. Next slide, please, Dr. Abhishek. So, cellular therapy is a big topic currently because we need to know and we've understood that the traditional medicines that we have been using is not as much giving providing us with either a treatment or a course or many of the cures that are there. So, we are working more towards cellular therapy, or these are also known as biotherapies. And ATOM, or the Asian Association of Transfusion Medicine, has started this initiative. Dr. Claudio is our honorary head of this cellular therapy. He's also the founder of this group. So he was the one who was running these before. Yeah. Next one, please. Sorry, Dr. Hatim, I think your mic is still on. Yeah. For me, I'm Dr. Asa. As most of you know, I'm a clinical pathologist with my background in certified advanced therapies professional and the American Board of Regenerative Medicine. These are my career highlights. I have around 21, 22 years of leadership experience in managing and operating diagnostic labs, cord blood banks, adult stem cell banks, facilities which are regenerative medicine, and now gene and cell therapies. I work extensively clinical trials, quality management systems, regular compliance, gap audits, and faculty for many of the organizations. And today I wanted to really proudly say that we are introducing a new team as well. So I am the chair. Dr. Claudio, Dr. Hind, they are honorary, chairs as well. My co-chair is Dr. Abhishek, and Nufal Rashid is the coordinator along with Dr. Jasmine, sorry. Today, I will not take a long time to introduce the team, but in our next presentation, I would like all my team to introduce themselves so we can, talk about more what we do. Next slide, please. So I took this from the website today, and this is a beautiful thing about Atom that these are 24 member countries, but I'm sure Dr. Chaudhary is going to correct me on this because we are adding so many other countries like Balkan countries and many of them who are a part of this transfusion medicine group. And there are around 1,400 plus total members, 1,000 plus academic hours, and 500 plus webinar. And this group was unfortunately not very active, but we are reviving it again. And if any one of you who's joining today would like to speak on a particular topic, please reach out to me or Dr. Abhishek. We will share our email addresses with you, and then we can, introduce you to this group as well. Next one, please. So when we talk about Atom is a manifestation of the determination of leading specialists in transfusion medicine from Asian countries, which are working towards, finding solutions for common problems. And this is where we believe in the spirit of friendship, trust, and understanding to create an order based on mutual respect, equality, and shared benefits. And as we know that we have a lot of other things which we're doing differently than many of the economically well developed countries. So we have all got our challenges and we learn from each other. And then we're bringing some of the best solutions to the rest of the world. Next one, please. So without further ado, I want to introduce my first speaker today. And as I mentioned earlier, I'll be introducing both the speakers so that we can, have this discussion uninterrupted. So Dr. Hatim Al-Abbas is going to speak on birth to healing, the benefits of cord blood banking. He is a PhD in immunology from the University of Khartoum, and he is the head of cord blood bank in M42. His clinical interests encompass immunology, immunogenetics, transplantation, and cell therapy. He has extensive experience in healthcare and lab medicine, having established labs in both public and private sectors. He led the establishment of the first dedicated lab for histocompatibility and immunogenetics research at Afad University in Sudan and the pathology department at Royal Care Hospital in Sudan. Additionally, he introduced NGS HLA technology to the Dubai Healthcare Authority or DHA, Dubai, and holds academic positions as an adjunct assistant professor at MBRU UAE and a visiting professor at Khartoum University, Sudan. He's a member of the executive board of the Arab Society of Histocompatibility and Immunogenomics and the National Committee of Cord Blood and Stem Cells in the UAE. His academic qualifications include a BSc in Medical Lab Science, an MSc in Immunology, and a doctorate in immunology from Sudan, and a diplomate of the of the American Board of Regenerative Medicine. Going to the next speaker today. Can we go to the next slide, Abhishek? Yeah. Um, Nagin Humayun Sarasht, she is going to speak on recent advancements in cord blood banking and its therapeutic potential because one is to bank the cord blood or do biobanking, but then what can we do? So she's going to speak more about that. She's the scientific consultant and a CEO of NHS Medical Surgical Equipment trading company here in Dubai. She's a scientific advisor who has over 13 years of experience in cell and molecular approaches, specializing in the establishment and management of GMP certified facilities for stem cell research, exosome technology, regenerative medicine, and genetics across the Middle East. Nagin has worked with some of the magnificent groups coming out of Iran, and Iran at this point of time is doing a lot of work in the clinical applications of regenerative medicine. I'm so happy to call both of them my friends, and I've known them for a while, so it's always wonderful to have them here. I think this is, can we go to the next slide? So, I didn't want to talk more about biobanking and cord blood banking because both our speakers today are going to talk about it. Without further ado, I will hand over this mic to Dr. Hatim. Dr. Hatim, if you can share your presentation, and Abhishek, you can stop sharing my presentation. Thank you.
Thank you, Asa, for the introduction, and thanks for the Atom for having me here in this and giving me the honor to present or to share uh, our knowledge and try to benefit from each other in this such and a great event, which is encourage people to share their knowledge. So I'm going to share my presentation.
Yes, please. Yeah.
Yeah, is it?
Yes, we can
Uh,
see it. Yes, yes.
So, talking about the cord blood bank and the cord blood technology or biobanking, as now it's called biobanking, it's a huge project and a huge field which start recently. We can say it's more than 40 years, but still in the medicine, it's a recent technology and recent medicine. So the cord blood mainly is the cord blood is the blood remain in the umbilical cord and placenta after the birth, whereas it contains large number of blood forming stem cells called hematopoietic stem cell, which is the reason why the cord blood bank coming. And there is a lot of another progenitor cells which is being used now for another research and as well as therapy in the cord blood banking technology and cord blood banking field. Storing of this cord blood bank for the unit we called it. It's by the end of the day we are naming it as cord blood unit. So why I'm telling this, because some people always refer it to cord blood sample. It's not a sample; it's a unit containing a lot of things, but we associate it with the samples in a matter of when we are going to screen it. So we are using the word sample. Cord blood banking as a field is a term of storage of hematopoietic stem cell harvested from the cord blood in the dewars or the tanks for now it's for 30 years as there is a evidence-based medicine, but I believe that when we got more data, it will be more than 30 years if it's being stored in an adequate temperature and being monitored as per the quality measurements. And it's mainly for the future use in stem cell transplant. Preserved after rigorous screening and testing and processing. So this cord blood, it's go through a lot of procedure for screening it in a matter of viral and in a matter of bacterial and other contaminants before processing, and then it will be processed, then it will be cryopreserved under very ultra high temperature and low temperature, sorry, which is 196 minus of the liquid nitrogen. So the history starts when before 40 years this cord blood has been used as a source of transplant or alternative resource for bone marrow transplant for a lot of diseases starting from hematological and other malignancies, red blood cell diseases, thalassemia disorders, bone marrow failure disease, and inherited transfusion dependent anemias. All this because of the, let us say, the gold standard for treating this is the bone marrow transplant. So the cord blood is becoming as alternative source for this, in especially in case of there is no suitable donors. So the stem cell from cord blood are collected, as we said, from cord blood, and recently from cord tissue, whereas different type of cell from cord blood mainly it will be the hemolytic stem cells, and from the cord tissue always or mainly it will be the mesenchymal stem cells, which is used now for a lot of therapy, especially in regenerative medicine field. It's a contain a large number of blood-forming stem cells. Collect cord blood is screened, as we said, before frozen. So the freezing itself, it's taking steps to freeze them because you are working in a normal temperature, in 4-degree temperature. Then you are freezing it. It's a process and a control rate freezing temperature, which is allowing you to keep it under protection or DMS or where we are adding that DMS as a protection factor for the cord blood cells to avoid any damage with that low temperature. So when to consider the cord blood as a source for hemolytic stem cell, as we said, for the majority of hemolytic stem cell transplant or condition, this option is allogenic transplant from a matched sibling for patients who do not have a match. So this is the reason why we are using the source or cord blood when you don't have a match living donor. Mainly for the because of the HLA barrier, you are preferring the sibling donors than the unrelated donors. So in case of there is no sibling donor, you need to go for unrelated donor. So the best resources here is the hemolytic stem cell transplant from the cord blood. If you have a good quality, good number and of the stem cells, which is need to be evaluated very carefully before doing this transplant. So nowadays they're using haploidentical family member where they're doing the transplant of it. So the haploidentical family member is a choice and the cord blood is another choice. So this is will give more of opportunity for the patient to recover from their disease if they have the option to have the matched cord blood as a donor. So the advantage of these procedures in allogenic transplant, HLA match is better tolerated because you don't need to go for 100% match. And this is even with the haploidentical, the cord blood is giving, as the literature is giving more tolerable HLA mismatches. Reduce incidence and severity of graft versus host diseases available more readily than marrow or peripheral blood are related donors, where the donor always the living donor, even he is a match or she is a match. Sometimes there is circumstances arise when you start doing the donation procedures. Sometimes the patient is getting disease or simply he rejected the transplant when this is coming. So the cord blood we consider it as off-shelf product, which is low viral infection because we are screening it. So it's ready, always ready. There is no such circumstance in having maybe the of withdrawing this donation. The disadvantage of these procedures unknown of donor background because we know well the ethnic group now it has some impact on the long term of graft potentiality. A lower number of CD34 because of the frozen effect. It's not a fresh samples. So of course during the long term storage, even they did a lot of study on that, but still the longest storage it will affect the viability of the CD34 and this will reflect of course in the recovery and delayed reconstitution and of course the cost of storage. You need to store this blood since starting the cost will start from donor uh, recruitment. You will start your cost till you release the sample or they release the unit. Till that time, you are paying money for keeping this sample in a high quality. And again, it's one-time availability. So if you have one match unit, for example, this one match will be used once because of the numbers, as we said, and with the volume because we need a high number of stem cells. So it's a one-time use. So the core blood bank, as we said, core blood bank is started in 1983, whereas the concept of core blood as an alternative source of stem cell for transplanted spheres proposed by Dr. Halvard Fire and colleagues. Then in 1985, they discovered in cord blood transplant, some stem cells are discovered in human cord blood by Professor Meyer again. 1988, the first transplant happened to the Fanconi anemia for Matthew. And 1992, the first public cord blood bank established by Pablo, and this is in New York. Then in 1993, the first successful unrelated cord blood transplant in the world is performed by Dr. Joan at Duke University. Then in 1985, where the first successful cord blood transplant for an adult leukemia patient is performed, followed by 1996, FDA launched investigation new drug IND for cord blood under the cord blood transplantation study, COBALT. And 1997, the first expanded cord blood transplant, 46 years old man with a chronic myelogenesis leukemia become the first adult to receive an expanded cord blood. And since then, the cord blood banking is going very, very fast. Even nowadays, still we are considering that it needs a lot of research and a lot of working as a group to emphasize on the benefit and the beneficial of this very valuable product. As per the cord blood today, now more than millions stem cell transplants performed worldwide. It's considered that 1 out of 3 people will benefit from stem cell therapy, whatever the therapy, more than 40,000, and nowadays I think more than 50,000, 60,000 cord blood transplants worldwide happening in the past, let us say, 25 years. Already used over 85 diseases, where more than 80 diseases are approved already by the FDA. 1988, this is the transplant we talk about it, and for the what's called cerebral palsy, more than 3 or 4 patients who was treated with they were treated with the cord blood, and this is a statistic by 2009. I believe that means a lot of things is happening always. As a cord blood bank, we have a different type of banking. So the banking is depend on the purpose of the banking. So either we will have the cord blood bank, public banking, where this is it's considered as a program and always funded by the government. Whereas it's a completely donation program. That means everyone is donated his cord blood and to be stored in the public cord blood bank, which is, as I said, always been under the governmental custody. And these units were added to the what's called the registry, so as to enhance or maximize the inventory of cord blood in the country. There is a private banking where the family, or we call it the family banking, where is the family came and preserve their own cord blood and to be used by them. And this is mainly happening in a lot of countries, and this is it's not a free of charge. This is the family coming and pay the cost of preserving and processing of their cord blood, and it will be ready for them whenever they need it. Hybrid public banking, this is when the bank having the two options, private banking and public banking. And nowadays, or before years, this coming community banking, maybe the India is the first people who are thinking about this community banking, where you are banking. Community banking, it could be defined as a mini public banking, whereas you are considered certain community in a concept of public banking, but it's a paid service where these people they are belong to the same community, the same ethnic group, who are donating or preserve their core blood and pay for that as a private banking. But the concept is these people they have the access to the whole group or the whole community banking. So this is will enhance their potentiality or their chance to get the match donor when it's needed. So the cord blood banking steps or the process is starting, it's mainly around four steps always, starting from donor recruitment and eligibility checking, then to umbilical cord blood or tissue collection, receiving it in the lab and processing it, then storing it and cryopreserving it till it will be needed for the transplant or for any cellular therapy. So this is the main four steps in any cord blood bank. So the recruitment process, which is considered the most important one, I believe, where the donor recruitment team going to the hospital, going to the medical centers, and through the media, they will enhance the awareness about cord blood. As I said, the cord blood technology or the cord blood field is new field. We consider it still new field, so it's need the people to raise the awareness about it. So this is the main issue about the cord blood bank donor recruitment team, where they have the awareness program. They are the owner of this, and in the same time, their responsibility is after education or after educating and counseling of the mothers and the parents to make them informed consent and take their consent about the procedure, especially if it's public banking. So in the public banking, you need the patient to or the mother to be very informed about her consenting, why she's going to donate and what's the benefit of that, what is going to happen for her sample after it's being collected, and especially her maternal sample, and what will happen for her cord blood when it will be collected, how it will be preserved, what is the data will come from that, and what is how you are going to review data, because the data now is very important issue. So keeping the data and confidentiality, it's very important in this field. So the donor history questionnaire or eligibility, this is very important to check the eligibility of the mother. There is, as per the ABB, there is a consent, there is eligibility questionnaire which is being given to the mother or to the parent. So as to answer this question, because it will help the core blood bank to determine this mother she's eligible to donate or not, she's eligible to reserve her cord blood or not. All this is through a very long questionnaire, which is mostly covering all the issue which can affect the eligibility. So after doing all this, and when the mother becoming or coming to the delivery, the healthcare provider will collect her cord blood, and either through the if it's a normal delivery or if it's cesarean section, in both ways they collecting the cord blood. We are doing here cord blood collection in utero, so the placenta is still inside the mother, and they will do the cord blood collection. Then the sample after being collected, it will come to our laboratory. The collection from the undelivered placenta is performed by a trained physician, of course, or midwife attending the delivery. The umbilical vein is punctured, cord blood is collected by gravity, so there is no any harm to the mother or to the child, because the baby will be detached from the mother at that time. So this is what is concern the mother always is it harmful for her and for her child. Of course, both of them they are be safe, and this procedure is completely safe for both of them. During the collection of core blood, we are facing some issue, and this is especially affecting the public banking or core blood banking, because in the core blood banking, we are requesting for its need that the volume to be more than 100 ml. That will give us a good number of stem cell as per the fat. For example, the minimum number for a stem cell CD34 positive to be useful for the unit for transplant is need at least to be 2 million cells. They found that 2 million cells you will not get it easily if you do not have in generally more than 100 ml of cord blood or 100 ml of the volume of the unit, because there is CBD, of course, in the cord blood unit, which is around 34 ml. So to get this volume, always for delayed cord clamping, it will affect the volume. And this is now, it's a practice by the obs and gynae, whereas they believe that the delayed clamping is very useful for the babies. That's why they are practicing it, and it may affect the cord blood collection. So in this case, we are explaining to the obs and gynae, we are explaining to the mothers what the benefit of cord blood banking and one benefit of delayed clamping and the drawbacks of all each of them, and we are free to the mothers are free to choice and to select, and by the end of the day the physician who is the one decide the baby need to do for need cord clamping or not. So just to explain that, or just to make sure for them that this procedure is completely voluntary procedure in case of public banking, and of course if it's private banking, it's bear their wish, so they are the one who decided, but still we are explaining to them what the mean of delayed cord clamping and what the recommendation of each society among the world about the Ops and Gyno Society. So this is the what is in the screen now, the recommendation of each society about the cord blood banking, and the length or the time of cord blood banking, of course, is not up to whitening. Some organization, they believe that the cord blood should be drained completely from the placenta to the baby so as to get benefit of it, and the other organization, they are very recommended this, and there is some organization like International Aviation, there is no group, or they declare that there is no group of benefit of this procedure, or they are not recommending it. Besides the cord blood collection and this, there is a cord blood tissue. Nowadays, people are concerned a lot about cord blood tissue because of collecting of mesenchymal stem cells from it and culturing it and making it as useful for the therapy. And we know that a lot of studies now working on the what's called the mesenchymal stem cell, especially in regenerative medicine. So after the blood collected and then the cord is being cut, 10 to 15 centimeters. They will cut the cord blood, putting in the special container, which is contained, recommended always to contain antibiotics with that media, so as to reach us to the laboratory. Then it will be processed as per the protocol in each laboratory, and then it will be stored as the cord blood is storing. And some labs they doing directly collection of or extracting of mesenchymal stem cells, growing them and store them, and some laboratories keeping them as tissue. Then later it will be extracted. So when the sample received in the laboratory, it's received as any samples, maternal samples, and the cord blood unit it will receive together in what's called kit. When we say kit, that means the box which is contain the cord blood unit and the maternal sample with the cord blood, because the maternal sample is very important, where we are sending them for screening for virology or most of the viral like HTLV, HIV, hepatitis C and D, to make sure that the mother is free of that. And this is as per recommendation, it should be done either in the same day of delivery or 7 days before or 7 days after the delivery, to make sure the cord blood unit, when it's received the lab, it's free of any infection or any contamination. Then the lab receives the sample in the receiving area, where they labeling it and labeling the cord blood unit as well with the ISBT number, which is the ISBT system. And because this is a unique numbering, it will be labeling for all cord blood units, and it will be unique as for the normal blood banks. Then there is here they doing physical check and as well as clinical check inside the processing area. Is a physical check. They will check the unit and they will check the attached document with it. Then they will weighing it because as we said, the weight is very important, where it will reflect the volume and then it will reflect how much is the cord blood, where it will be expected to have a good number of stem cell and TNC or not. By the way, the public banking criteria is completely different than private banking criteria. And this is why, because the public banking, it's anonymous sample. When we receive it, then we keep it in the storage, and the donor here, who will not be identified with the name and with the gender and everything, but it will be identified as a ISPT number. But the private banking, the name is there and it's a family banking. And that's why when you have the cord unit and you have the baby who bring this cord unit, when he's born, then you will have, even if it's lower number of stem cells, you can do double transplant, taking bone marrow and with the cord unit, so you will overcome the shortage or the lower number of stem cells. But in the cord blood banking, since you don't know the donor or the donor will not be there, it's only the donor you will cord unit, then you have to have a good number of stem cells too, which is at least 2 million and above. So after weighing the samples, we go to the processing area where they will do the virology testing for the samples, and for the unit they will do the flow cytometry and CBC, where they measure the eligibility of CD34 and CBC TNC. And from this checkpoint, when you get the numbers, you are decided you are going further or to stop. So this is, we call it the checkpoint. Whenever you do any test, you are evaluating your procedure. If it's passed, CBC and CD34, then the unit will go for final storage. During this processing, we are taking also blood culture. We send the blood culture for culturing the cord blood, and we are waiting till the result comes. So when the result all comes, the virology result and the sterility testing for bacteriology and mycology, then the unit will be ready for final storage, where it will be in the final destination in the tanks. Before that, it will be in what's called quarantine tanks, where we keep it there for 14 days till we are receiving all the samples. The idea behind that, we are making sure that the sample which will, when it will go to the final destination, in the final destination, these units are completely free of viral and free of any type of contamination, and they are high quality according to the criteria and the banking criteria, which is bank 4. This is the methodology which most of the laboratory using, either using manual separation or semi-automated with the AXP and fully automated with the CPAX machines. This is why this is different type of processing. By the end product of all this processing, is you need to reduce the volume where and to get the pure stem cell or cord blood stem cell with free of any contamination. CRF, this is the CRF, where is control rate freezer. This how we are bringing this sample or bringing this cord unit from 4 degrees centigrade till minus 145, where it will be ready to be going for the storage. The last one shipping, when the sample is retrieved for transplant, you need to send it for the transplant centers, and to keep it in the same temperature where you are storing it for these years. So again, this shipper or dry shipper is full of liquid nitrogen. This is the whole process which you are talking about, it from the collection, processing, and cryopreservation. So your cord blood now is ready for retrieval. This is maybe this diagram, it will tell us how potential is the cord blood placenta and the cord blood tissue, as well as the cord blood itself. So this is different platform or different approach for the use of this very precious materials. where you can use it in as a hemolytic stem cell for transplant in this beta thalassemia, sickle cell diseases, and other blood cancer and disorders. From the core tissue, you will get mesenchymal stem cell for therapy and research. Uh, this is mesenchymal stem cell. Placental tissue, you can use them or now using them for diabetic foot ulcers, vein leg ulcers, and in another ophthalmic problems. BRB and tissue repair regeneration is still also you can use the plasma there or platelets for wound healing, joint and soft tissue repair and hair, and joint and hair growing. Exosome, which is a new novel of drug delivery. It's a targeted molecule delivery. Dr. Asa, she's very expert on these things. She can, if there is a time, she can talk about this exosome, and I believe it will be a very novel thing, and it will be a very beneficial for the as a therapy. Ah, so now the most of the people now thinking how we can use this cord blood in a proper way, like what we have here, we have a whole genome sequencing. So we think about when you diagnose the disease and you have the source for treating it, you can reach a good let us a good sentence of health. So you have the whole you can diagnose, make the whole genome or expecting the disease, expecting what will happen, the potentiality of that. Then you will have the resources as stem cell, whatever the type of stem cell. Then at that time you have the insight and you can plan the disease which will affect, of course, the economy of the country, and it will affect the will be with great beneficial for the whole community. To summarize, these banks are related or related donor cord blood is a routine source of donor cells for patients lacking a match related or unrelated adult donor. Nearly 800,000 unrelated units are banked in public banks, and more than 5 million samples are stored in a private bank. So look to the different people are looking for always for private banking, but I believe that if we can alter the people to go and do it in a public banking, it will be more beneficial for all the societies. Multiple clinical trials in progress to explore the efficacy, application, and promise of cord blood. There is optimism in the cord blood community that cord blood units can be used as a source material to develop cellular immunotherapy, creating a new application for cord blood. Immunotherapy is a relatively new field of medicine in which the native cells of the immune system are multiplied or modified so that they do better job of fighting cancer or viruses. Many are now working with T cells sourced from cord blood and natural killer cells sourced from cord blood in a lot of researches. So the idea is the ease of availability of match and match cord blood units to treat number of conditions is unrelated in unrelated patients. This is I think it's a big benefit of the cord blood. Cord blood does not require exact match HLA to be transplanted in patients. Long storage of cord blood units for a number of years, more than 20 years. Liquid nitrogen levels are minus 196 degrees Celsius. Ready source of hemolytic stem cell cord is available with ease for a large number of patients when compared with the bone marrow. As we said, treats a number of diseases, more than 80 diseases are treated. This is the way, including cancer, blood disorder, genetic and metabolic diseases. And the success rate of cord blood, as per the literature review, the success rate of cord blood transplant is significantly high. And I think it will be growing even in the 90s, it's declined. But this is because of a lot of cases now. The public banking facing real problems, maybe more than 85, because of the high rejection, because of the low volume, of course, contamination rate, and the sustainability. So we encourage all core blood banks to try to sustain their financials by doing research. Try to use this as a cellular therapy, which is regenerative medicine now is going to grow, and this is I believe that this is the source of the cord blood or the stem cell from cord blood. It will be a vital role in this. So by this, I think I'm ending presentation. Thank you, Dr. Asa, for having me again.
Thank you, Dr. Hatim. I would love to have questions. If you have any questions, you can please share them with us. Without further this thing, I would like Dr. Nagin to start her presentation. Dr. Hatim, if you can stop your screen sharing, Nagin can share. Thank you.
Hello, Dr. Asa, and all the attendees. Thank you for having me. Thank you for your invitation. Nice introduction. Thank you, Dr. Hatam, for the great presentation on the basics of and fundamental important points for cord blood banking. Let me share my presentation now.
Yes, we can see it. If you can make full screen. Yeah. Fantastic.
So, thank you. Today I'm talking about recent advancement in cord blood banking and therapeutic potentials. As an introduction, you all know that cord blood banking has many advantages over other sources of hematopoietic stem cells. The main reason is that it's so accessible rather than the other sources. It doesn't cause any harm or damage to anyone, pain-free, and the rate of GVHD comparing to the bone marrow samples are less. Also, it has over 80. It can treat over 80 diseases and conditions, which is FDA approved. So as the cord blood can expand into different type of cells like red blood cells, white blood cells, and platelets, also having the potential of regenerating the tissues, reproducing themselves. They are highly used in regenerative medicines and for cancer treatments, non-cancer conditions, immunotherapies. So I will start with 1960s when the first hematopoietic stem cell was found in the bone marrow transplantation to a mice. And then in 1988, as Dr. Hata mentioned, the first successful cord blood transplant happened on Matthew Farrow with Fanconi anemia from his sibling, which now he is healthy. And later on, we saw many advantages, many progresses on cord blood banking, either on therapeutic use or clinical trials. So the first public cord blood bank was in 1992. Then since then we saw many progress on the collection, on the storage, on the processing, and on the storage. So early processing of hematopoietic stem cells was manual, and later on we saw advantages and progresses on having, excuse me, automated procedures on XP, CPACs, so many other factories like Macopharma, Macopress, Miltenny Biotech, and other companies joined for this advancement. And cryopreservation techniques improved from freezers to controlled rate freezers, and then deep freezing in minus 196. Expansions in the way of banking from public banking and private banking was transformed and went through under many regulations and standards like ABB, FACT, and NetCord, which allowed us to preserve standard samples and which allowed us to be able to transit. Sorry, I'm just getting better. The past 2 days I was so sick.
So,
Um,
I hope, yeah, all okay. Yeah, good.
yeah, I just took some water. So since then, we had many other improvements in the clinical applications for many treatments. One of them was ex vivo expansions that it was, I think, about 2 years ago that FDA approved ex vivo expansion of hematopoietic stem cells for a specific condition. And even for using for adult patients in some clinical trials, we saw that they are using expanded cells or dual cord blood transplantation rather than using single samples were applied. Recently, they are using gene therapies, gene editing technologies like CRISPR-Cas9 on hematopoietic stem cells and mesenchymal stem cells to improve the outcomes. So as a comparison on methods of collections, firstly, it was just based on the gravity. Then they used some syringes. Each one of these ways has its own pros and cons for contaminations, for the number of cells that were collected. Later on, some sterile bags were used with anticoagulant, with CPD, CPDA to make it easier. And some centers are also using the placenta drainage to get the total volume of the cord blood that they can. For the processing methods, many methods have been applied, like volume reduction by centrifugation, removing plasma on RBC. RBC depletion, some centers are using special solutions to reduce the RBC, and then by centrifuge, get rid of the excess plasma. Automated procedures, many devices, AXP, CPAX, MacroPress, some devices from Thermo Fisher and Milton Biotech has been applied to do all the things within one closed system, and at the same time, centrifuge is within the devices. So they can get rid of RBC and excess plasma at the same time and separated in each bag. Even some centers are using those plasma for different reasons, having applying them on regenerative medicine, making plastics for Oscars rejuvenations, tissue rejuvenation, and rest are sending samples. The main Buffy code, which contains white blood cells, are preserved separately. And one of the old methods is whole blood cryopreservation, which some centers believe that if we store the whole cord blood, it's more beneficial, all the components together, but it needs a huge space to store them, and you need a huge amount of cryoprotectant, so it was not cost effective enough. Methods of cryopreservation have changed a lot. First, they were using just freezers. Some of them some centers started using slow rate freezers, which later on we saw that manufacturers are producing automated cryopreservation, with at the same time they were also able to check the real time rate of the sample freezing, what's happening inside the chamber. Vitrification was one of the other methods that it was ultra rapid freezing altogether, but it needs a special cryoprotectant. And dry freezing, some centers as a trial are using to see how it works. But in contrast, we have this discussion that cells need to be alive, and to be alive and stay alive, you need water. So further applications and trials with using cord bloods are being applied in neurological disorders, for cerebral palsy, for autism, for hypoxic ischemic encephalopathy. These are the things, these are the trials that have been followed up in many research centers, including Duke University, which is a pioneer in clinical trials. And they have released many publications based on the outcome of their studies. In some other slides, I have described it I have explained it in details. They have used cord blood in regenerative medicine. By cord blood, we just don't mention that hematopoietic stem cells. Cord blood also contains mesenchymal stem cells, which is very beneficial for immunosuppressions, for anti-inflammatory aspects, and for rehealing and rejuvenations procedures. In orthopedic, in heart disease, lung failures, we have seen many clinical trials applying mesenchymal stem cells extracted from either Wharton jelly or placenta or any birth-related tissues. Ongoing researches on using cord blood includes the stroke recovery, spinal cord injury, diabetes, and autoimmune diseases. MSC's shown progresses on these conditions, like in spinal cord injuries called cord blood-derived oligodendrocyte cells, or sometimes we try to guide the cells within the laboratory, guide the cells to go through different growth pathways in order to be used in different parts of the body or different organs or different tissues. In diabetes type 1, especially, I think it was 3 weeks ago that another successful clinical trial results were published. Also, they are using some gene editings and gene modifications on the hematopoietic stem cells to make them to be more potent in order to fight with the cancer conditions. Recent clinical trials in many locations around the world showing great progress in healing conditions and treating different diseases such as neurological disorders, brain injuries, immune deficiencies, degenerative diseases, skin abnormalities. I just put some of the recent ones. Here you can see which method they have been used. Either it was allograft or autograft, it was single unit or multiple unit, which we will describe them later, and what are the criteria that you should select. Based on which criteria you have to select whether you should go with single or multiple, double, or something. So criteria for selecting single or double unit. Patient weight is so important because we need to make sure we are infusing enough cells for the patient to reheal the immune system. So total nucleated cell TNC and patient weight are in a parallel formula for treating patients. Next topic is CD34, which are hematopoietic stem cell progenitors. These are the cells that we are looking into them for recovery, for neutrophil, basophil, and different type of cells to see how fast we can recover the immune system of the body, how fast we can recover the hematopoietic stem cells. HLA matching is very crucial for any type of hematopoietic stem cell transplantations. Compared to bone marrow or peripheral blood, cord blood transplantation can be done with 4 out of 6 HLA match, with keeping this in mind that at the same time it has low GVHD risk. Disease type that we can go through that we can check whether we should use single or double unit depends on the nature of the disease. So sometimes to treat a cancer patient, we need to use double units. And sometimes if the amount of the cells are sufficient within the weight of the body of that child or adult, we can follow the single, depends on the condition of the patient. Engraftment speed is very important. Single unit has lower engraftment speed rather than double unit. Still, we have this that in double unit, one of the units that you're injecting will be as a dominant and lead the procedure of the treatment of the patient. And GVHD is another factor which is so important. If you're using double units, you're putting the patient in a higher risk for GVHD. But sometimes because the number of the cells are not sufficient, we have to go through that. And cost is always important in any type of therapies. Risk and complications, as I told you, the lower risk of GVHD and easier finding a donor is with single one rather than the double. But in double, you can get a more higher TNC numbers and better outcome results, better speed, but you have the risk of GVHD at the same time. Another factor which is affecting the engraftment is conditioning regime. So myeloablative regimes that the patient is go through them will affect directly the transplantations and the toxicity of after transplantations procedure. Cord blood cell recovery and engraftment within a timeline. So for us, after the engraftment, we have to check the blood work of the patient. Usually neutrophils are more important for us because they are leading leading immune system of the body. And it's very important for us to make sure that the patient will be healthy soon. So the first thing that we check within first month is neutrophils, but at the same time keeping an eye on platelet, red blood cells, and immune system T cell and B cells. The last thing that will take more time within 1 year are T cells and B cells to recover, and the patients are at high risk of infection within that first year. Single unit recovery for neutrophils is about 25 days, and for double units is around 21 days. Again, depends on the situation and the weight of the patient. Post-engraftment monitoring the factors which are very important is the cell count, which I emphasized on that, is the GVHD, which will put the patient at high risk within the first 100 days, and immune system recognition. Why it is important? Because within the first month after transplantation, still the immune system of the body is so weak, and need to take a good care of that patient in 1 year, in order to let the B cells and T cells to get back on the track. Chimeric testing is another important factor because we want to check that the infused cells to the patients, the donor cells, are they going through the bone marrow? Are they going through the right direction, taking over the immune system or not? Organ functions and late effects on transplant, like kidney, like sometimes lungs and heart, after the chemotherapy or radiation or some immunosuppressing drugs that doctors have to prescribe. This is one of the factors that we have to look into. And also for cancers and secondary effects on the cancer treatment. Bone density testing is very important. Routine cancer screening for leukemia is very important.
And again, it's okay if you have a few slides. How many slides do you have now?
Maybe 10 more.
Oops. Okay. Is it okay for us to, have it in the next 5 minutes if that could be done? Yeah.
Okay, I will wrap it up.
Okay.
At
Thank
the same time, we know that after any type of transplantations, the psychological effects of that transplant, especially if it's a cancer condition, it's very important to check the patients, check the family, whether they're still healthy, mentally healthy enough or not. So to check all the standards and to see that whether on the processing, collections, and transplantations we are aligned with something which is agreed globally, we have to gain some accreditations for the stem cell facilities. AABB Fact, NetCourt Fact, and many other more. The most important one are GMP, which is the basic and first one. We have to make sure that the facilities who are releasing these samples have these accreditations and they are on the same page. In some cases, we need to ship the sample from Europe to USA to GCC. So we need to make sure that all the samples are on a good quality. For cord tissue banking, we also have other accreditations for cord related to the cord tissue. HTA is for the UK. CGMP is current gut manufacturing because sometimes you need to do more manipulations on the tissues. ABBCT and FACT-CT are also applied. Some of the leading cord blood banks in the world, I just named a few of them. One of the greatest one is really cord in India, but CBR, ViaCord, Cryocell, and another cord blood bank in China, which these days are doing a good job in terms of treatment rather than just storing of cord blood samples. And Cryosave in Netherlands, these are top fives, I can say. And as I mentioned, Duke University, since like more than 20 years ago, started the research and doing clinical trials using cord blood on different situations. And the outcome is very interesting, although they are not FDA approved still. But many people are willing to go under these clinical trials rather than just sitting and watching the conditions, what's happening to their child, what's happening to their family members. So in conclusion, I would like to emphasize on this point that cord blood banking, whether it is public or private or family or community or whatever, it doesn't mean that we have to just store the samples for the future, which we are not sure that what will happen. It's also about finding ways, finding potentials, finding more treatments, sometimes in combination with peptides, with exosomes, with different drugs or drug delivery processing, gene editing, to be able to use them for the patients that we also have right now. We already have them and they need help. Thank you, everyone. Thank you for listening.
Thank you so much, Nagin. Thank you so much. Thank you, Dr. Nagin, Dr. Hatem. Thank you so much for your talk today. Any questions from the audience? Abhishek, do we have any questions from anyone in the audience, in the chat?
I don't see anything in the chat, madam.
Okay. Would anybody would like to ask the questions directly to the speakers?
Hello, everybody. Hello, Doctor.
Hello.
Also, I have a question about cord blood HLA matching criteria in new era with introducing NGS. Is there any changes in HLA typing criteria for cord blood bank? And what is criteria for HLA matching of dual cord blood transplantation?
Dr. Hatim, question for you.
Yeah, if I understand, the criteria is not for the cord blood itself. It's a matching donor to the patient criteria. As the HLA, as general, the fully match is preferable always. But in the cord blood banking, as per the study, they found that even 6 out of 8 or 8 out of 10, it will be considered as a good match in a matter of the, 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 the shelf life of the organ when you donate it, or in this case, the bone marrow or the stem cells. So in the matter of NGS, always now the high resolution is recommended. So when you screen for the transplant, you always, because of the cost, you are always doing screening method for because you are looking for a donor. You are doing by Luminex, for example. When you find a potential donor, you are doing high resolution. And in some laboratory where is there a high throughput, they are doing directly high resolution because again it's the cost. But there is no what's called the criteria between. It's a matter of matching between. Here we consider the cord unit as a donor, and the patient is the patient. Yeah.
Yeah. Thank you so much. Any further questions from the audience today?
Hi, Doctor.
Hi.
Thank you for the great talk. To both Dr. Hatim and Nagi. As an outsider, as a common man, actually, like I have a question. Like as an expert in the industry, how do you see the expansion technologies will improve the usability of cord blood, mainly for the adult patients? Actually, like. Thank you.
Good question, Santosh, and good to have you here.
I believe, Santosh, that with regard to the expansion, if it succeeds and if still there is a debate about it in hematopoietic stem cell expansion for the transplant, even they doing it for a long time. The main purpose of expansion to have more cells to cover the low count, or to avoid using two samples, because as you know, for the adult patient or the high weight patient, you need more than one unit. So to have a fully matched 2 units, it's not an easy job. So this is one of the benefit of the expansion, when you expand 1 unit and to make it good number for to be suitable for the transplant. But of course, if it succeeds in the proper way and it's done, everything is going in the best way, as we think, it will be benefit for the let us say the more weight or the adult patient, because as we know, this unit or 2 units, it will be good for treating 80 kg per 80 kg, providing that the calculation of the units or of the CD34. So it will be benefit for sure if it's go in the right way. So Nagi, what do you think?
Nagin, are you able to take? Yeah.
Yes, yes. So I think as long as right now we're focusing on what FDA is providing information. At the same time, if DEA is so much restrict that would not allow any type of like, it's a good point because it's human health. We should take care of that. But at the same time, I think depends on the situation of the patient. If it is cancer, if it is immune disorder, or if it is metabolism, depends on the situation of the treatment that we can look into whether we should follow the expansion of hematopoietic stem cells or not, whether it's beneficial for the patient or not. Maybe sometimes in cancers we should be more strict and stay on the same rules that was released from the regulations, or maybe at some points for treating the adult patients we don't have any other choice, otherwise we're losing the patients, we can look into the expansion.
Thank you. Thank you. I hope, any further questions from any audience? Please feel free to open your mic and talk or, ask questions. I think till the time we have more questions, I had one question for you, Dr. Hatim, and one for Nagina. So I think my question was going to be, Dr. Hatim, where do we see biobanking? I mean, we talked about cord blood banking. I think in the next session, I want us to come back and talk more about, other sorts of biobanking from cord tissue, placenta, bone marrow, even adipose for that matter, because where do you think this field is now going? Maybe for you as well as Nagin, I'll ask this question.
I think that the future will be for this field of biobanking, because if you go to the medicine now, it's becoming as precision medicine, targeted medicine. So to do studies, you need these biobanks in a matter of research, in a matter of developing of regenerative medicine. Again, you need this biobank or this field. So for sure it will be the coming days. Most of the and it's by now the medicine always depend on data. So, and special data for each ethnic group, with data for each country, data for, and this is will not be provided unless you have a good biobank facility, which you can store all this data on it and make it available for research as well as make it available for therapy, because we are coming to the era of precision medicine. So everyone he will have his own medicine, and I believe to reach this goal you need this biodata to be stored, and you need the sample to be available.
Thank you. Thank you, Dr. Hatim. Nagin, over to you.
I look into stem cells as an accelerator for any type of therapies. Like if you want to do gene therapies, you're doing apheresis. If you're able to collect like stem cells from the either bone marrow or cord blood, and you try to use those gene editing on the stem cells, you will accelerate everything more quickly. It's by their nature that they put them their potential for making more cells and making themselves regenerate. Even for exosomes coming out from stem cells, maybe more beneficial. So keeping stem cells always with us, it's a good idea. But at the same time, I think it should be more into practice, more into treatment, more into research, clinical approaches to rather than to make them more beneficial for everyone, rather than just storing them for many long years and nobody knows what happens after 30 years, after 60 years. I know that we have too many papers on the viability, on the speed of the recovery speed after transplantations, even after 10 years, 15 years. But nowadays, with gene editing and many advanced treatments, I think we can get more benefits from stem cells within the application, within the laboratory.
Absolutely, absolutely. Thank you. Thank you so much. I think looking at what we have initiated now, and I know today was our first call, that too in the middle of the week. We're hoping to, maybe look into Fridays or something like that where we can have a larger audience. Plus, this is a recorded session, so this recorded session will be played by different, or will be shared in the groups, and then people can look in the YouTube channel to, learn more from this. Once the recording is available, I'll share with the speakers if you would like to share more with your, other people as well. I think looking at this, my next session, we will be initiating this as a series. So I'm really looking forward to having both of you back on various aspects of it. I think Dr. Hatim, today one of our audience participants, they were very interested in HLA and how to do that. So